Welcome to Connecticut eHealth Podcast, educating, conversing, and connecting for better health. The Connecticut eHealth Podcast is a space where we get together with local and national experts, key stakeholders, and other individuals in the space of eHealth to discuss health information in Connecticut and around the country. This podcast is brought to you from the UConn Health Interoperability, Innovation, and Learning Lab, where our mission is to promote the optimal adoption and use of eHealth by providing education and engaging in conversation with leaders to create connections for better health. So let's sit back and get connected. Hello, my name is Tom Agresta. I'm a family physician and a clinical informaticist at the University of Connecticut, and I'll be your host for this episode of Connecticut eHealth Podcast. Today's guest is Dirk Stanley, who's the Chief Medical Information Officer at UConn Health. I've known Dirk for a number of years when he was prior Chief Medical Information Officer at Cooley Dickinson Hospital. He's received his bachelor's in business management from the University of Massachusetts, a master's of public health and epidemiology at New York Medical College, and he graduated from St. George's University Medical School. He's an internal medicine trained and did his residency at Albany Medical Center. And it's my pleasure to kind of welcome you, Dirk, and have you talk with us today about your experience, the things that you've learned as a CMIO or Chief Medical Information Officer, and also as just being, heavily involved in technology and medicine over a number of years.
Sure. Thank you very much.
So, Dirk, tell us a little bit about yourself and how you became involved in the field of clinical informatics, and a little bit about what your vision of what clinical informatics actually is.
Sure. So I guess my journey to informatics started even before medical school. I worked for about 5 years as a data analyst at the Westchester Medical Center in Valhalla, New York. And I learned during those 5 years, it was the same period when I was getting my master's in public health. I learned through multiple work examples of the importance of good data, getting good data out of the computer. But I also learned the importance of getting good data into the computer and making sure that it was predictable. If you don't collect the right data, then you don't produce the right data on your reporting. So eventually that led me through my master's degree. I worked briefly for EMS, and I went to medical school. And I took all those lessons with me right into medical school. And of course, when you're in med school, you're busy just studying anatomy and biochemistry and pathology and all these diseases. But when I started doing my clinical rotation, I saw the way people were using technology at the bedside, and I saw some problems. I saw sometimes people entering data into one computer system to generate reports that they would re-enter into another computer system. And I think anyone who's worked in healthcare has probably seen examples of that, or trying people faxing prescriptions that could have been sent electronically, or that sort of thing. And I used to say, I think there's a better way to do this. But I always thought it was funny because before I went to medical school, I would often ask questions about, what are these diseases we're studying? What is vancomycin-resistant enterococcus? And people said, well, you're a technology person. You're not a doctor. You don't really understand. That's not your problem. Don't worry about what VRE is. And then afterwards, now I'm wearing a white coat and a stethoscope, and I'm thinking there's a better way to do this. And they said, oh no, you're a doctor. You don't understand technology. What would you understand about technology? So that eventually led me through residency, where I was very heavily involved in various computer projects. And eventually when I got out and started working as a hospitalist, people discovered this talent, and that's how I landed my first job as a CMIO. So that's my journey.
Interesting journey. It's similar to many other sort of CMIOs who came about it by their background. It's similar to my journey, I would say, in terms of I had technology skills and then added the medical skills and couldn't understand how come they really weren't being utilized together. So it's a wonderful opportunity to be a CMIO and have that background. And as in your role as CMIO, what kind of pain points did you experience as a clinician yourself, and also have other people express to you that you really want to solve?
Well, I think, my role, I work fairly closely with pretty much every medical specialty at our hospital, and I hear from a lot of department chiefs. I hear from frontline physicians, and probably, the number one thing everyone is looking for is a way to make their job easier and less clicks and more efficient. And how do we how do we do better at diagnosing disease, and how do we do better at treating disease, and how can I do that in the computer system in a nice, smooth, user-friendly, patient-friendly, doctor-friendly, nurse-friendly, pharmacist-friendly sort of way. And that is how that eventually led me to a lot of questions about workflow and design. And yeah, so I think the number one thing people are looking for is easier access to information faster and at the right time. Like, the information that they're looking for has to be displayed at exactly the right time for people to be able to make decisions.
So you sort of are hitting on something I know that's been a major passion of you, and that's sort of integrating, technology into the workflow of clinicians. And for those that don't know Dirk, he's actually had a blog online for a number of years. We'll share the access to his blog in our show notes. And doing things in an appropriate workflow manner has been a big part of your sort of passion, I would say. Can you tell us a little bit more about this workflow integration that you're describing?
Yeah, I think one of the challenges with all this new technology that's rolling out is, you want it to create a seamless user experience. You want it to feel right. I've heard people describe good workflow as it's like you're walking down the street, and just the moment that you're thirsty, somebody hands you a glass of water. Just the moment that you're hungry, somebody hands you your favorite sandwich. And just when you're ready to do your whatever your work is, the desk that you're looking for is right there with the work open, and that it should feel that sort of experience. And so I try hard to deliver that experience through really careful analysis of what are the clinicians trying to do, first of all, and then developing blueprints for what should that experience look like to minimize the number of clicks and maximize the diagnostic and therapeutic activities that they're doing inside the computer. So I think when you build it from a user standpoint, and by user, I don't just mean doctors and nurses and pharmacists, I mean also patients, right? You want to make it from the people who are interacting with the technology. Why are they interacting with it? And what are they looking for when they interact with it? And how are they going to interact with it? And you have to really get deep into the details of, exactly what the screen should say, how it should display, even sometimes things like fonts and colors and, where the buttons are located are very important in making that seamless experience. So that's the kind of stuff that I look for.
Yeah, it is so important, and as both a user of that healthcare technology myself in my clinical roles as a family physician, and also someone who plays a similar role in trying to design things better, I know that it can be quite a balancing act to have technology support you in just the right way. Can you give an example of something that you did, in the last year or two that kind of demonstrates, this for folks who are kind of not aware of what it means to kind of design for the workflow?
Yeah, so actually I have a very good example of something, probably the most dramatic example I can give you, although I have many examples of workflows that we've ironed out, but probably the one that stands out the most to me is with my previous employer. We were struggling with unfractionated heparin, and heparin, for listeners who may not know, is a blood thinner that's commonly used for people who have heart attacks or blood clots, and it's really life-saving medication for people who are having acute blood clots in places that they shouldn't have clots. So we're having a number of problems with the way the heparin was being ordered and monitored. And heparin is one of those drugs that you have to monitor very, very closely. You have to look at the drug levels and how the person is responding to those levels. And it's a very complicated dance between a doctor, a nurse, a pharmacist, and even the laboratory plays an important role in how heparin is managed. So we redesigned the heparin workflow from scratch, and literally from a blank sheet of paper, and through many, many iterations and interviews with doctors and interviews with nurses and pharmacists and laboratory people. And we redeveloped the workflow from the ground up using all new evidence-based literature to show what was the best way to do this. And this is a workflow that's not even really provided by the manufacturer of heparin. The manufacturer basically gives you the guidance, like, use the drug correctly, therapeutically, and, make sure that you're, giving the right amount of the drug. But they don't really give you detailed instructions on how to know what the right amount is. So it took about 9 months of design work, and a lot of people, I got some very raised eyebrows during that time. Why is it taking so long to redo this? But when we redesigned it, we redesigned every single step from beginning to end. And we made sure that even in places where somebody might forget what they're supposed to do, we even built in fail safes to make sure that if somebody was late in responding to a laboratory result or something, that the appropriate measures would be taken to make sure that the patient was safe and that the drug continued at the correct therapeutic level. And so we redesigned this, and when it was launched, not only did it win best practice with my former employer, but it was actually adopted as a best practice across the entire health system. So today, if anyone were to have a acute coronary syndrome or a pulmonary embolism, pretty much anywhere in the state of Massachusetts, it's my heparin workflow that is being implemented to save people's lives. And that's kind of a neat thing. That's what I love about clinical informatics. Those blueprints help save lives, even right now as we're speaking. I like knowing that I'm helping people all around.
That's an amazing story, Dirk, and it reminds me that quick fixes aren't necessarily good fixes, and while it's hard to sometimes see that it's going to take so much time and effort to invest in something, especially when you're creating something reusable across many organizations, what you end up doing is actually saving quite a bit of time and money in the long term. And then, of course, the real value is in saving lives and improving lives. And that's a wonderful story. So transitioning a little bit, I know that UConn Health has recently joined our state's designated health information exchange, Connie, and that it's begun actually connecting with some tools that can allow for data to be retrieved and viewed, and also is contributing data into the health information exchange. Can you speak a little bit about what the implications might be for UConn Health in your role as CMIO for having a health information exchange that has data from throughout the state?
Yeah, actually, Connie to me is a real breakthrough in the way we exchange health information. And just to sort of frame my sort of views on this, exchanging health information is absolutely vital in delivering care to people. If you go to hospital A for, let's say, your primary care, and then you need a specialist and you need to go to hospital B, the specialist can't effectively treat you unless they have the records from hospital A. And that portability is what I think healthcare technology is really all about. And that's the holy grail, right? Being able to be a patient, and no matter where you go, your information follows you, your med list follows you, and your allergies, and whatever surgeries you've had, and so we're all looking to achieve that level of record portability. And some of that has been overcome. Some of the software vendors have ways of interacting with particular vendors to exchange that health information, and I think that's a very helpful tool. But Connie, I think, opens up a whole new opportunity to not only have data portability with hospitals who might use different vendors, but also for the people in the state of Connecticut and in the greater Hartford region, and really through the entire state. Being able to exchange that information is absolutely vital for disease monitoring, for public health initiatives, for things like researchers who are looking to study pediatric diseases. I think often about the public health implications of what happened in Flint, Michigan, when they uncovered the problems with the lead in their water. And that was quickly identified because they had access to information throughout the state. And there was a pediatrician who actually found out that there was a wide discrepancy in lead levels in one area versus another. And if they hadn't found that, you would wonder how long that problem would have gone on without anyone intervening. So I really believe that these public health initiatives and data exchange they make good sense. They make good clinical sense, and they make good user sense. I think patients are looking for better portability. Pretty much every patient I've ever spoken to says, why every time I go somewhere, they keep asking me the same questions over and over and over again. And, why, and, doctors and nurses are always saying, why are we having such a hard time compiling somebody's medication list? And this is where I think Connie really can play an important role in helping to create that level of exchange. And it's very exciting to me.
Yeah, you gave that great example from Michigan and the public health benefit, and also, the obvious one of, patients expecting their data to travel with them in today's day and age. But it doesn't always work that way. And so it's wonderful that we have a health information exchange now. Can you tie together the importance of your conversation a little bit about workflow and about the health information exchange a little bit? Because I know that will be one of the areas where we're going to need to design perhaps, a more effective way where we're going to have to adapt over time. And I think the things you're describing about thoughtful planning might be very helpful.
Well, so in terms of workflow, so Connie now opens up a whole new opportunity of, like, I think of it almost like a whole new toolbox that we can incorporate into the frontline clinical workflows. Because to make something helpful, you need to have the right information. I call it the 5 rights of information, right? It's getting the right information to the right person in the right place, in the right time, in the right way. And that part, getting it there at the right time, you need the information to be available at a point where somebody can make a decision that helps improve health, or that helps improve life, or that helps make something better for somebody. So now with Connie providing, this opportunity, this really great exchange field, so now it's another tool we can incorporate into those workflows to help with not only, prospective decision making, but also retrospective, data aggregation and studying public health trends, studying patient trends, studying what, even for things like making budgetary decisions. Where should we spend our money as a state? I think having access to that information about, what are the common things, like if there are areas that have, problems with nutrition, like knowing where to intervene to help people who, might have health inequity, right? We want to make sure that we offer an opportunity to everyone in the state. And I think Connie allows us to better understand where the inequities exist and how to address them.
That's a wonderful example. And with that example, I think we'll take a brief moment to kind of hear a little bit about Connie and then return for some additional questions. We want to take this opportunity to thank Connie, Connecticut's official health information exchange. Connie was established in 2019 to oversee and provide services to support the exchange of health data in the state of Connecticut. Connie is an independent and not-for-profit organization. To learn more about Connie, please visit conniect.org or go to the show notes from today's episode. So Dirk, now returning to our conversation, and as you think about integrating the use of a health information exchange at UConn, can you talk a little bit about things that you're desirous of for the health system, but also things that may be challenges or barriers to integrating health information exchange into the everyday work of our organization?
Yeah. Well, now that Connie is available to us, we're looking through all these new tools that we have available. And I think some of the sort of easy, kind of low-hanging fruit that we would like to pursue would be even just patient interchange between other hospitals. And, like when we transfer a patient, for example, from UConn to one of the other hospitals, or when those hospitals transfer patients to us, sometimes, different hospitals have specialists in different areas. And sometimes if it makes sense to be able to transfer patients from one hospital to the other. So we want to provide a more seamless transfer workflow. And this gets to then, Connie is fairly new. And so going through all of the opportunities, we really have to work through some of the challenges like data interoperability. Just because the data comes through doesn't mean it's actionable. For example, if one type of specialist at one hospital documents very differently than the specialist at another hospital, then we have to sort of develop, we have to have meetings and talk about the governance and how are we all going to document so that we can, understand each other's information, or what are the data elements that are necessary even, when we transfer patients. Having those very real meetings with doctors on both sides of the fence is an important step in developing that interoperability. So even though it's technically the information is coming across, we want to make sure that it's helpful information for both sides. And that's where, I think one of the challenges in going forward is looking at clinically, what do we need? What does everyone need? And then how do we achieve it? And so I anticipate there's going to be a lot of partnership with other healthcare institutions and having really great, and this is why I love my job, having really great clinical conversations that then drive us to how are we going to use this new technology? What is the best way everybody can put data in so that the people who need the data out can, effectively manage the patient?
Yeah, it sounds like there is going to be plenty of time to work on those things because, as you and I both know, those are sometimes they're technology challenges, but to a large extent they're sort of use case and business, decisions, and really sort of how do we design the workflow to get the data in the right format and the right way to share amongst our organizations. And kind of going across that, if you had to pick several pieces of data or several types of data that you think would be most beneficial right away or most beneficial in a short term, what would you think they might be?
Oh, MedList is number one, right? I think that's been a challenge since the beginning of healthcare technology. And it seems like such a simple thing, but when people go from, their primary care to the emergency room to their cardiologist to, their dermatologist to all these different doctors, to the pharmacist, what ends up happening is everyone has a slightly different take on the same story. So having one central place where we can have all the med lists will really have a major role in, safety, in making sure that the patients get the prescriptions that they need, making sure that we don't have drug-drug interactions when other people prescribe. So I think MedList would be number one. Number two, allergy list. That's another, sort of easy target, I think, for making sure that you have that. Number three, knowing who your primary care provider is. Like right there, that has a major role in managing patients. Your medical history and your surgical history, those are also very, very important. And then there's often other details that are important, include not just your name and age and date of birth, but how you identify your gender, other special needs you might have. There are people who have language needs when they see their primary care doctor, and knowing how to anticipate that is all information that I look forward to using Connie to exchange that sort of information.
That's wonderful. And as you probably realize, that one of the main use cases that they're working on is trying to develop an actual best possible medication history, or BPMH. And that's been a goal in Connecticut for some time, and trying to get to, I would say a forward movement on it, but probably not perfection, is one of the things that's actually going to happen in the next year with the Health Information Exchange. So that's a great set of ideas. What about untraditional, data sources or types of information? Is there anything that you can think of that would be really helpful in caring for patients, especially from a public health hospital like UConn Health, which takes care of, a wide array of different patients?
Yeah, there are people, there are people who have sort of bread and butter. I think it's often called bread and butter diseases, like, diabetes and high blood pressure are common ones. But there are people who also have very uncommon diseases, right? There are people with, rare types of cancer, metabolic diseases, rare skin diseases and stuff like that. And some of those people are on medications that require very careful monitoring, and being able to bring their lab work and their radiology is really, really vital for disease maintenance and knowing how to move forward. Some drugs, you want to make sure that they don't impact the kidneys or the liver. So being able to have access to the, kidney labs and the liver labs and stuff like that plays a big role in not only how you monitor the drug that the person is on, but also what other drugs you might prescribe. So those are also vital for disease management.
Yeah, I can't agree more, and especially since as a specialty hospital, UConn Health will often be caring for the most unusual types of diagnosis in patients that they might have. The other thing that becomes important is that there may well be organizations that healthcare organizations, primary care clinicians that are very underfunded, under-resourced, and in that way have information silos. How could you envision connecting to those types of organizations, since it really does become important as a tertiary care institution that UConn is?
Well, so here's an area that I know you know very well. When you're the primary care provider responsible for a patient, that's a big responsibility, right? You're the captain of the ship who's kind of watching everything that's going on, and we do have a number of independent primary care providers in the state of Connecticut, and giving them access to information across all of these specialists and all these different healthcare organizations is absolutely vital for them to be able to oversee the health of the patient. And I think this is another area where having that interoperability allows those people to maintain their practices in a clinically effective way, like that. Instead of having to hire extra staff to try to get records from different hospitals, just giving them easy electronic access I anticipate would make it much easier for them to maintain their daily operations.
Right. So you're talking not just about workflow and easing the burden on them. You're actually talking about maybe reducing the cost to provide care, and that's actually really important. Something we haven't really discussed much in our conversations to this point. And if you were to say, like, what are the key elements that will make a health information exchange successful in our state, what are the few things that you would say not would just be measures of success, but would also help with ensuring success?
I think ensuring success will depend on really, people buying into a shared tool. This is a shared tool from the state of Connecticut that everybody benefits from, and knowing that it's not there to provide more support to one organization than the other. It's there to provide support for really the patient, right? It's there for
Absolutely.
to allow their information to be exchanged. I often think, and I've met with a number of patient advocates who express their frustration with healthcare not having information interchange. And I think we have an obligation to the patients to make sure that we provide them good, seamless care. And so I always use the patient as my sort of, compass in these discussions. And I think making patients aware of that the tool now exists, and patients even asking their provider, like, does your institution interact with, Connie? Like, how does your institution interact with Connie? Like, what kind of information are you using it for? I think patient involvement is really, really important to ensure buy-in. And then I guess the other thing is having a shared governance, right? Making sure that the people who decide on which data elements are being tracked and how they're being managed, making sure that you have the appropriate body to oversee the continued, not just the flipping the switch to turn it on, but the continued maintenance of Connie. Like, I think having that shared governance and having good patient awareness can really help drive the utilization of Connie going forward.
Yeah, I love your focus on the patient. One of the key driving factors in even the design of the health information exchange, and that came out of discussions from the Health Information Technology Advisory Council for the Office of Health Strategy, which would kind of develop the initial set of use cases and framework for how the HIE was going to be, and the governance structure actually for how the HIE was going to be set up, was that the patient is the North Star. And I think that if we keep our focus on that, we're all patients, all of our families are patients. And we need to remember how we would want to be treated in clinical environments, and how we'd want our data to flow as well. And I think that that's kind of critical. So in closing, this has been a very interesting conversation, and I really appreciate your insight and your thoughts. But in closing, what do you hope that UConn Health can bring to the partnership with other hospitals and other primary care groups, et cetera, but also to working with our state's health information exchange, Connie, and what do you hope to gain from it?
We really look forward to, joining and participating and being a vital part of that discussion, because as you and I were just saying, really the patient is the true north of this discussion. And so, we want to serve those patients. And so we look forward to participating. I'm working with some of not only our technical team, but also some of our clinical leaders to look at the tools and really, take them out of the box and figure out how to incorporate them into our workflows to deliver better care. So we're eager and ready to, start talking about these best case scenarios for using this new technology.
Excellent. And with that, I think we shall kind of move on and allow you to get to work on integrating the tools, and for us to learn from what you've said and bring that information back to Connie to help them be most successful. So thank you very much, Dirk, for your time and wisdom in this conversation.
Thank you so much. It's a pleasure being on your podcast.
As always, wishing you the best of health. Your host, Tom Agresta.